us about yourself.
Okay, so I'm a nephrologist practicing in Northern California. I originally got interested in bone working with kidney dialysis patients, less to osteoporosis, and am institute director of the Northern California Institute for Bone Health, which is a nonprofit foundation. And as many people know, a team physician for the Oakland Athletics and have been a team physician for the Golden State Warriors and the Oakland Raiders, where I'm now back as a bone consultant. Oh, okay, this is my disclosure slide, and we're going to be talking about what is now known as chronic kidney disease, mineral and bone disorder. And we're going to be talking about stage 2 to 5, and this is really an update for everybody. So during the 2000s, the National Kidney Foundation came up with this classification of the stages of chronic kidney disease. And I put up this slide so we can all be starting at the same point. So stage 1 is basically normal kidney function. Stage 2, there's mild loss of kidney function. And you can see the estimated GFR in the rightmost column, 3A, 3B, and then stage 4, estimated GFR of 29 down to 15% of renal function. Stage 5, kidney failure, where there's less than 15%. And then there are stages related to dialysis, transplantation, etc., which we're not going to be discussing.
Can everyone please mute your phone? There's a lot of background noise, and we want to be able to hear our speaker. If you could just mute your phone, that would be great. Thank you. Go ahead, Dr. Schwartz.
Thank you. So the fracture risk is very high in stage 5 CKD. There's a 50% prevalence of fractures. There's 50% excess mortality as compared to age-matched controls without stage 5. And fractures you can think about occurring 10 years earlier than age-matched BMD patients without CKD. And hip fractures are extraordinarily high in this group of individuals. So in about the year 2003, the National Kidney Foundation came out with a first set of guidelines that was Kidney Disease Quality Outcomes Initiative, KDOQI. But in 2009, the KDIGO organization, which is Kidney Disease Improving Global Outcomes, came out with their set of newer guidelines. And we're going to look at parts of those guidelines. So this is a graphic from an article in JBMR and shows the different types of bone disease and the different patterns over time that they can occur with. So at the top, hyperparathyroid bone disease, mineralization defect, which is osteomalacia, low turnover or adynamic bone disease, low turnover aluminum, and then at the bottom, osteoporosis, which you can see the pattern getting wider and wider as you progress from end-stage renal disease to dialysis, and then in patients who are transplanted, and then in patients who have to go back to dialysis after a failed transplant. And this is from the KDIGO guidelines, looking at the different percentages of those bone diseases as we pass from stage 3 to 5 to patients on peritoneal dialysis and patients on hemodialysis. So I want to point out to you basically the most important component probably for this discussion is the AD or adynamic bone disease, which is present in pre-dialysis patients, but then in peritoneal dialysis increases to a prevalence of about 50%, and in hemodialysis patients is about 20%. And these percentages of adynamic bone disease have been increasing over the years for a variety of reasons. So these are some of the guidelines that I want to touch on as we'll talk about them later. So in patients with CKD stages 3 to 5D, 5 dialysis, it is reasonable to perform a bone biopsy in various settings. Now, I know bone biopsies are not available to most of you. We do bone biopsies. And if you have a big institution and you're going to see a lot of patients with CKD, then it's helpful to have one person trained to do bone biopsies. And most of them are done by nephrologists, but at UCSF, we have them performed by an orthopedic surgeon. The labeling and everything else takes place by the nephrologist. Then this was the 2009 guideline. It said in patients with CKD stages 3 to 5D with evidence of CKD MBD, we suggest that BMD testing not be performed routinely because the BMD does not predict fracture risk as it does in the general population, and BMD does not predict the type of renal osteodystrophy. There they're talking about hyperparathyroid bone disease, adynamic, etc., the things we saw in that blue and red slide. So this was 2009, okay? And then it's suggested that you get PTH or bone-specific alkaline phosphatase because those particular bone markers are not really changed due to lack of excretion. But it said not to routinely measure the bone-derived markers of collagen synthesis, such as P1NP or the cross-links of collagen. So this guideline was reevaluated, and a new update, partial update, has been formulated. So we'll discuss some of those changes. Now, we're used to doing FRACs in most of the patients. I don't have time in this discussion to go into all the issues, but the FRACs tool is decreased in its performance in patients with kidney disease. So what has to be done to change that is a big discussion. Maybe we can get into later. Okay, this is a slide from Susan Ott and shows the complexities of what's going on in bone disease. I don't expect you to remember this, but just say a lot is going on, lots and lots of changes in the peptides in the body, and this is why postmenopausal osteoporosis, where there may be just an estrogen deficiency, is not analogous to CKD MBD, where there's 20, 30, 40 changes going on that we know about at the present time, and probably will understand more changes as time goes on. So when I see these patients and I'm doing a secondary workup for bone disease, there are a lot of other lab tests that I get beyond just the typical ones. And one that I want to focus in on for this discussion is the FGF23 there in yellow in the right-hand column, or fibroblast growth factor 23. So if you look at this graphic, I don't know if I can move my pointer, but we used to think that the first thing that happened in chronic kidney disease, bone disease, was the elevation of the serum phosphate level. But we now know that that's a very, very late change. And then we thought, well, parathyroid hormone goes up, but that's not a very early change. So it turns out that FGF23 is a marker of the presence of CKD MBD. So what do I mean by that? This is from an ASBMR meeting in 2013. Dr. Ruska from Washington University in St. Louis stated that the FGF23 is a powerful biomarker that can be used to gauge the onset and severity of CKD-MBD. So early in CKD stage 2, that's stage 2, after a few nephrons are lost, a signal is sent, we don't know exactly how, from the kidney to the skeleton to the osteocyte, which makes FGF23, that an osteodystrophy, some abnormality of bone exists. The osteocyte starts secreting FGF23. A normal FGF23 indicates that CKD-MBD has not started. An elevated FGF23 indicates that CKD-MBD has started and that all of the other changes that we talk about then start to follow. So what we do is we use an FGF23 level to tell us if there's CKD-MBD. Otherwise, the patient has routine postmenopausal osteoporosis or male osteoporosis or glucocorticoid-induced osteoporosis, but they do not have superimposed CKD-MBD. And that'll become important when we're trying to decide what therapy to give. Okay. So again, stage 4 and 5, diagnosis of exclusion, biochemical and histomorphometry are what we use. So we look most easily at the PTH and the bone-specific alkaline phosphatase. So basically, we look at the extremes of PTH. If it's less than 100, it's going to be more likely the patient has adynamic bone disease. If it's greater than 600, it's going to be more likely that the patient has osteofibrosis cystica or hyperparathyroid bone disease. A low bone-specific alkaline phosphatase has a high predictive value for low bone turnover. So if you get both of them, the PTH and the bone-specific, and you combine them, and they're both low, you have a high likelihood of having adynamic bone disease. If they're both high, you have a high likelihood of having hyperparathyroid bone disease. And there's been dozens, if not more, articles written on combining and adding different molecules, but these are probably the best at the moment. So then came an update in 2015 that we realized that the pro-collagen peptide, which is their type 1, pro-collagen type 1 terminal propeptide, P1NP, and tartrate-resistant acid phosphatases are not available, are metabolized by non-renal mechanisms. So for many of these patients, you can also add in P1NP. So then 60% of the fracture patients had a femoral neck T-score less than -2 and high levels of either serum osteocalcin, P1NP, or the TRAP5B. So we're trying to employ more markers to give us a non-invasive idea of what's happening with the metabolic bone disease in these patients. So then, as you saw from the guidelines, the 2009 guidelines said not to do DEXA. But this has now evolved to the new guidelines, and there are some points here that, as we emphasize over and over again, hyperparathyroidism, primary, secondary, is anabolic to trabecular bone and catabolic to cortical bone. So if you have these patients, you want to look primarily at the cortical bone sites like the 1/3 forearm. So now, furthering the update, we now know that there is a relationship between the BMD by DEXA and the fracture risk, which was not known in the 2009 guidelines. So in the old days, for a postmenopausal osteoporosis patient, we would say that for every SD decrease in the BMD, that there was a 2 to 3-fold increase in fracture risk. That was in general. Now, for the CKD MBD patients specifically, we can say that for every 1 SD decrease in spine BMD or total femur, there's a 1.5 or 2-fold increase in fracture risk. So we have that fracture risk relationship. So let me skip this slide. So now in the new guidelines, it says we suggest BMD testing to assess fracture risk. So that is a change to the guidelines, and you are well within your rights to do DEXA, particularly using the 1/3 radius cortical bone site when you're evaluating these patients' fracture risk. And the more that goes down per standard deviation, the more the fracture risk goes up. Okay, so then we also have trabecular bone score, which I'm just going to touch upon. But this is one of my CKD MBD dialysis patients, and she had a trabecular bone score that was classified as degraded. So when I see a degraded trabecular bone score, right away I'm thinking probably an anabolic drug for this patient. Okay? So then in the new guidelines, again, they talk about performing a bone biopsy. So this is from a patient that was presented at UCSF nephrology grand rounds, and the doctors thought that she should take Prolia, denosumab. Okay, so this is her bone biopsy. It shows basically very low turnover. There's not much going on in that marrow. This is the report. So there was a dramatically low bone formation rate, and although she did not have adynamic bone disease, she had diminished osteoclast activity, which meant she would not be responsive to an anti-resorptive. And as the report said, Forteo might help to stimulate increased osteoblastic activity. So here, the bone biopsy helped us to move away from the anti-resorptive to an anabolic medicine. So the value of a bone biopsy in these patients, if you can get them. So then I want to talk a little bit about treatment and the medications that we have available. So this is a slide from a post hoc analysis of the fracture intervention trial data. Okay, so in those earlier studies, patients were excluded from the trial if their serum creatinine was at an elevated level, 1.75, 2, etc. Okay, but then after those trials were completed, the National Kidney Foundation popularized the use of the EGFR, or estimated glomerular filtration rate, which is now available on almost every chemical panel in the universe. And so the authors went back and analyzed the patients in the clinical trial, not by their creatinine level, but by the estimated creatinine clearance. Now, on the left-hand side of this slide, you can see some gray bars. And in the paper, that was called severely reduced renal function. But it didn't correspond with the NKF stages. So on the bottom, we can see some of the information related to the creatinine clearance and then use that for the NKF stages. So if you look at this, you see that most of the patients were in the stage range from 45 ml per minute down to 30 ml per minute. And that is stage 3. From 30 down to 15 is stage 4. So I have never been able to find out how many people were actually made up that little bar below the 30 mark. But various people like Susan Ott and others who are involved in the data collection have told me that it was probably less than 20. And the CKD5 stage is 15 down to 0. And you can see there were no patients in the fracture intervention trial, the big Merck lendronate study, that had CKD5. That is our problem, okay? And that problem is repeated over and over again. So this is from a study by Ammerling where he gave alendronate to people already on dialysis and subsequently biopsied them after varying amounts of time on alendronate. And they all had low turnover. Now, as in the rightmost column. Now, unfortunately, we don't have pre-biopsies, so we don't know if the patients had low turnover before they were started on alendronate, but this is just a warning that you have to be really, really careful in dialysis patients because they may have adynamic bone disease and you may make it worse by giving them an anti-resorptive drug. Okay, so then this is the teriparatide data, okay? And if you look on the second column from the left, GFR, these are the 5 patients who were below 30 ml per minute or who had stage 4 disease. Now, if you look, 2 of those patients were on placebo. So that's not helping very much. 2 of those patients got 40 micrograms per day, which was one of the arms in the clinical trial, but is not the approved dose. So only 1 patient got 20 micrograms and had CKD below stage 3 or stage 4. And again, there are no patients that had CKD5. So again, leading up to our major problem. So this is a paper that was co-authored by Paul Miller, and this is a case report. You can read there, but basically this patient had a bone biopsy after years of chronic kidney failure and transplant and dialysis, and the initial bone biopsy showed low turnover. The patient was treated with teriparatide 20 micrograms subcutaneously daily in the AM and after dialysis on dialysis days for 2 years. The fracturing stopped. They had a repeat bone biopsy after 2 years, and that showed improved histomorphometric parameters. So we would be worried that these patients would develop hypercalcemia, et cetera, but this patient did not. So that's the extent of our knowledge on the use of teriparatide on dialysis patients. Okay? So then we've all been told that denosumab is not necessary to have a dose adjustment in patients with renal failure, and that patients may be contraindicated if they have hypocalcemia. You can give more calcium and vitamin D to build up. But what is the truth of what we really know? So this is a study that was conducted by the company that produces denosumab, and this was looking at what?
Robert.
Yeah, I'm trying not to be commercially apparent here. Okay, so anyway,
Autofluency. Okay, thank you.
this is looking at the pharmacokinetics of denosumab in patients with CKD down to the number 8 of patients who had CKD5 and on dialysis. Okay, but you can see the size of the groups here are really small. Now, the bottom line shows that they got it for 112, they were followed for 112 days. But this was a single subcutaneous dose of 60 milligrams. So we don't have any series where the patients got multiple doses to see what happens. But the pharmacodynamics and pharmacokinetics at least did not really change very much. Okay? Okay, and this is a look at the bone turnover markers of the serum CTX, and in all the groups, they went down just as you would expect in the patients with normal renal function. Okay, this is a slide from, again, a post hoc analysis of the fractures in the large freedom trial, okay, by renal stage on the bottom. So you can see that in the patients that have creatinine clearance of 15 to 29, which is CKD stage 4, okay, that there was still apparent fracture reduction due to denosumab, and it may have even been slightly greater fracture reduction, or maybe there were more fractures in the placebo group at that point, but there's certainly a significant reduction in fracture down to stage 4. Again, no fracture data from stage 5 or dialysis patients. Okay, so
Dr. Schwartz, can I respectfully interrupt real quick? So basically, at this point, looking at the review of everything that you're sharing with us, treating the CKD patient, stage 4 and 5 is really, it's kind of opinion-based. We don't have a lot of great evidence around that. And so it's good if we stay in touch with the nephrologists that are involved in these patients' care. And if we see that their GFRs are less than, well, actually they fall within
30. Less than 30, I would say.
Less than 30. We should communicate with the nephrologist and at least discuss, the plan for a biopsy. So I do have a question because we want to have time for people to ask questions. And I don't want to.
There's about 2 more slides in.
Okay, great. I'll let you go ahead and finish then.
Okay. So anyway, let me just skip ahead to here. So the management of patients with CKD stage 5 is no data, only opinion, as you were stating. Okay, and earlier this year, there was publication in the Annals of Internal Medicine of the article cited here, which was actually the review of all the medication data for the new KDIGO guidelines. And basically what they said was here. There's unclear rigor of evidence, there's possible reporting bias, and there's scant evidence among the patients with stage 3 to 5 what to do. So those are the patients that may have an elevated FGF23. If there's no elevation of FGF23, you can treat the patients just like you would postmenopausal osteoporosis or male osteoporosis. And the effect of this osteoporosis medications on BMD, fracture risk, and safety among patients with CKD are not clearly established. So stage 1 to 3, as I said, you could manage as PMO or idiopathic male osteoporosis. FGF23 is not elevated. Some using PTH and bone-specific alkaline phosphatase in the stage 4 and 5 patients. Fractured 4 and 5 CKD without biochemical evidence of osteomalacia. Off-label use of bisphosphonates or teriparatide. On-label use of denosumab. Fractured 4 to 5 CKD that you don't know the turnover, or with a low PTH BSAP, we would choose an anabolic drug now. Okay, that's the last slide.
And I think you're muted. Nope. Still can't hear you. Nope.
Okay. Well, why don't I still ask if there's any questions or anybody wants to say anything about the presentation? Ask a question.
Elliot,
Yes.
Mike Lewicki here in Albuquerque. Maybe this is a philosophical question, but why is it that dialysis itself is not an effective treatment for renal bone disease? If you're correcting virtually all of the metabolic abnormalities associated with CKD, and assuming you're not poisoning the patient with aluminum, why doesn't that take care of the problem?
Okay, because getting on kidney dialysis is not normalizing the renal function back to an estimated GFR of 90. You're lucky if you have an estimated GFR, if you could measure it, of 10 to 20. So you're still having advanced kidney problems, and you're not actually fixing a lot of the problems. You may be ameliorating some, but we do not understand what are the uremic toxins that are circulating. So we actually have no idea if dialysis is clearing minimal amounts of the uremic toxins, some of the uremic toxins, or a lot of the uremic toxins. So we're not in any way restoring bone disease. The kidney status. Now we do better with a transplant, but we don't necessarily even there restore renal function to normal.
So why is it that a transplant doesn't restore the bone disease?
Please mute your phone. Can everyone please mute their phone?
Okay. So, again,
Everyone, please remember to mute your phones. Whoever's walking around with a bunch of people in the background.
okay. So, Mike, you want to repeat that question? Why?
Yeah, the question was why doesn't a renal transplant serve as an effective treatment for renal bone disease in all cases?
In all cases, because the level of renal function that is restored is not always normal. Some people get a creatinine clearance of 20 cc's a minute, which is enough for them to get 100 without dialysis, whereas others get a creatinine clearance of about 60 ml, and they're doing really, really well. Then if you want to talk about, which we didn't mention, peritoneal dialysis itself may actually increase the rate of, or the prevalence of adynamic bone disease by constantly infusing calcium into the body, etc. So, you know, what you really need, I suppose, is to genetically take somebody's cells, create their own kidneys, and give them back entirely normal kidney function. That's not likely to happen in our lifetime. Any other questions? Do we have Ann back?
Can't hear Ann.
Elliot, can you hear me? This is Kara.
Yeah, I can hear you.
So how good are our commercial assays for FGF23?
Okay, well, so that is the usual question, like how good are our assays for PTH and a variety of other things. So we're basically dealing right now with what are first and second generation assays. And if the PTH story is any indication, we'll have to get several generations of improved assays. But right now we're dealing with what we have. So, like dealing with a total PSA as opposed to a free PSA or further breakdown. So right now they're the best thing that we have, but the assays I'm sure will improve over the next 10 years.
Thank you.
But,
Can you hear me now?
and I would say just for the purposes here, that LabCorp and ARUP do their own FGF23 and Quest sends to Mayo. And Mayo does FGF23. And most of the FGF23 levels that I've worked with have been done by the Mayo Clinical Lab.
Did you say what the cost was? I apologize that my audio keeps cutting me off. It's not me, it's just, but did you say what the cost of that test was and what the diagnosis would be?
No, but it's probably somewhere around $300.
And we would use a diagnosis of CKD, or what would be used to get that covered?
Yeah. Because, so N25.0 is renal osteodystrophy.
Okay. All right, wonderful.
And then, you know, if you wanted to put like N18.3 or 0.4 or 0.5, that's the different stages of chronic kidney disease as discussed by the National Kidney Foundation.
If you don't have a way of getting the bone biopsy, could you do the FGF23 as a replacement for that, or would you need both, or?
The FGF23 is an early marker. So it tells you when the patient has converted from routine postmenopausal osteoporosis or routine male osteoporosis to have superimposed CKD, but it's not a marker of adynamic bone disease or something of that nature. That's where you use the bone-specific alkaline phosphatase and the parathyroid hormone level. And if those are both low, the patient has a high likelihood of having adynamic bone disease or low bone turnover.
Other questions?
I have a question.
Yes.
Can you use the FGF23 after renal transplant to determine whether CKD-MBD has improved or resolved?
Well, if the FGF23 was normal, you don't have CKD-MBD. So yes, you probably could. But I'm not sure, let's say Mayo Clinic, 180 units is the upper threshold of normal. I'm not sure anybody has looked at if the FGF23 went from 500 to 300, whether that's an improvement in bone disease.
Any other questions?
There's a question here on my screen that says, do you recommend monitoring the FGF23 routine for patients with reduced kidney function? If you want to know if CKD, MBD has started, then you could do that yearly or every 2 years or whatever. The FGF23 is an early marker starting to go up in stage 2 disease, but it may not be abnormal until it's elevated in stage 3.
Okay, wonderful. Excellent. Any other questions?
Okay, you know how to get a hold of me if you need me.
Thank you. Thank you so much.
Okay, and now we have some time for a case study. Anne, do you want to go ahead?
Yes, can you hear me?
Yes.
Okay. So you guys get the luck of me today because we didn't have anybody else send in a case presentation, but I need your advice on this patient. And can you scroll down just a little bit so I can see, well, up, I mean, a little bit, I'm sorry, so I can see the whole screen. So this is a 47-year-old female that presented to me after she had had a periprosthetic fracture. Her history is that she was 31 at menopause after she had a total hysterectomy with oophorectomy for endometriosis. She was never treated with any hormone replacement therapy. She's in fairly good health at this point. She does state that she's had at least 2 or 3 falls in the past year or so. She describes herself as being clumsy. So I have sent her for physical therapy for falls prevention and core strengthening. Her fracture history is the one that I mentioned. She had a motor vehicle accident in 2014 and ended up having a subsequent left total knee replacement. Then she had a fall in 2017 and had a periprosthetic fracture, which led her for the referral because they felt like her bone quality was concerning at that point. So she has a family history of osteoporosis, medical history of reflux. She's been on chronic pain medications in the past. She currently is on Suboxone. She has anxiety disorder. She is a current smoker, but is trying to quit. And I discovered her vitamin D insufficiency. She actually was pretty deficient when I first saw her, and then we've actually kind of got that a little bit repleted. And then her history of early menopause. You can see her list of medications there. She's still taking Chantix after a year and still smoking, so there's still obviously a goal problem there. She's on Spiriva and not on a PPI, was actually on a PPI for a couple of years and then was switched to an H2 blocker in the past couple of years. She has chronic constipation issues, and you can see that she's on an SSRI and also an NSRI in conjunction with Suboxone. Go ahead and scroll down a little bit more. Very good. Again, she does smoke. She denies any alcohol intake. She has had about a 1-inch height loss since her 20s that she reported. She really did not have any unusual findings on exam. But her T-score, as you can see in her hip, was really quite concerning, and obviously her radius as well. I did not do any vertebral imaging as of yet. I did not feel it was a need, actually, just based on her height loss of only 1 inch. Her main clinical risk factors are that she's a current smoker and she had a previous fracture. So looking at her labs, I want to point out what I've done, because when I initially saw her, she had an extremely low vitamin D. Actually, the one that I drew secondary. The first one that she had in the hospital was 8. So when she came to me, I redrew it, and it was only 17, so her PTH was slightly elevated. I saw her back about 8 weeks later and rechecked it, and she had not been taking her prescription that I had given her, so I had to reorder that and get her back on that, get her started on that, and then had her come back. So her second PTH was 139 with her vitamin D of being 18. And then now I just had her come back in yesterday for a recheck because I wanted to put her on an anabolic, but obviously my concern is her PTH issue going on. And I'm waiting on her secondary vitamin D to come back, but you can see her PTH is still elevated at 121. So my first question is this her body trying to correct for the vitamin D insufficiency? Is this osteomalacia? Her phosphorus was normal, so I have a low, it's hard to consider that it is. I've got celiac antibodies pending, but what do I do from here if I'm not going to be able to use an anabolic on her based on her age? She obviously needs treatment. Where should I go from here?
Okay, Ann, this is Elliot. First thing I would say is a lot more vitamin D. Whatever you're giving her is not enough, or she's not taking it. So
Say a lot more. Can you specify? Because I give them 50,000 units weekly for 8 weeks, along with vitamin D3, 2,000 units daily, and then after they finish the prescription, they stay on 2,000. So I usually would just increase their D3 to 5,000. But where would you go from here?
well, for each 1,000 units, I think, I forget, for each 1,000 units, you're going to raise the vitamin D, I think, about 6 units. So I would personally give this person 50,000 units of vitamin D like 3 times a week for a month. And we want to get her vitamin D level without really good evidence-based information to probably 40 to 60. And then I would look at the PTH after we got her vitamin D to 40 to 60. And when we got her vitamin D to 40 to 60 and her PTH to relatively normal, then I would think about an anabolic agent. I agree.
Are there any concerns for pseudo hyperparathyroidism in her? Or you think it's all related to her vitamin D?
Well, right? When you hear hoofbeats, don't think of zebras. So let's just replace vitamin D and see where we get to.
How long would you wait before not treating her because she's at such high risk?
Well, I would be using an anabolic agent, probably off-label in this situation, to help heal her periprosthetic fracture. But she would probably get it approved for having had a fracture and having osteoporosis on bone density testing. And I think that you're going to be able to normalize the PTH, and I do not think her very low 1/3 radius bone density is due to hyperparathyroidism or primary hyperparathyroidism. I think it's very likely to be secondary hyperparathyroidism because her serum calcium is not elevated. Her serum calcium is probably near the low end of normal. And even a corrected calcium would not be that high. If we corrected the albumin to 4.5. So more vitamin D.
All right, wonderful. Any advice, Chase?
Well, this is Mike Lewicki. Just a comment. In general, without very much evidence, I like to see the 25-hydroxy D level be at least above 20 before I start any osteoporosis medication. So that's my rule of thumb. Now, you ideally might want it above 30 and maybe get it up to 40, but I think in general, if it's over 20, it's probably safe and likely to be effective to go ahead and start treatment. One other comment, if a patient has had long-standing vitamin D deficiency with an elevation of the PTH, it may take a while for the PTH level to come down. So it's possible that you could correct the vitamin D deficiency and the patient may still have a lingering elevation of PTH. And I've seen patients where it's taken as long as a year for the PTH to come down to normal. So occasionally that may be something that might happen and something you could take into consideration.
So what would you do? Because if you correct the vitamin D and the patient's bone density is still bad, and we know that there's not really fracture risk reduction efficacy with just vitamin D and calcium, and she already has the osteoporosis. Yes, you're treating the underlying problem, but she has the osteoporosis and she's at high risk. Do you just put them on an anabolic then until it corrects? I mean, an anti-resorptive until it corrects itself, just to give them some protection, or do you just wait that whole year? I'm a little bit nervous about that.
No. I'm not saying to wait a year. I'm saying to in my mind, if the D level is approximately above 20, it's okay to go ahead and start treatment, even if the PTH level is high. I wouldn't wait a year if they're at high risk for fracture. You could use a potent anti-resorptive agent such as denosumab, and it may well be that even if the PTH is elevated, that they could respond to an anabolic agent. So there's certainly case reports that's been the case, and Elliott has done that. Paul Miller has done that, and they've described patients having good responses under those circumstances.
So what would you monitor in terms of PTH if you did start an anabolic in this patient that was their vitamin D's, up to 30, their PTH is not yet normalized, but they're not over 200 or whatever. What would you monitor in terms of therapy with pulsatile dose anabolic? Would I need to keep an eye on the PTH, or
No.
is there some monitoring I should do?
I don't think you need to keep an eye on the PTH. There's a theoretical concern that if someone has an elevated PTH that might be due to normocalcemic primary hyperparathyroidism, and you start an anabolic agent, that they might be more likely to become hypercalcemic. So if that's of concern, you might pay extra close attention to monitoring the serum calcium level.
Okay, wonderful.
But the way that we would monitor this is with bone turnover markers. So I see you have a baseline P1NP. So we'd like to see the P1NP at 3 months, 6 months, and 1 year, and a new DEXA at 1 year. And probably a CT every once in a while for her periprosthetic fracture to see if it's healed.
So what would you expect your P1NP marker to go up post-initiation of anabolic? If you're checking it at 3 months, what would be a good end for knowing that they're taking their treatment or they're having a good treatment response?
Okay, so Kelly Crone says that data that they collected at Lilly showed that if the P1NP went up 10 units, that was a significant response. But I would like to see a doubling of the P1NP. So I'd like to see 120, 130 at 3 months or 6 months.
And this is Steve Ng.
Dr. Ng.
Hi. One thought here was to get a 24-hour urinary calcium to assess for hyper or hypocalciuria as another reason for the secondary hyperparathyroidism. And if you get that, address those underlying issues.
Okay. Excellent. Thank you. Well, we are at 5 minutes to close, and I just wanted to see if there were any final questions before we sort of wrap up our very successful Project Echo FLS today. Any final questions? All right. Well, thank you so much. I want to say thank you for being on today. Make sure that you turn in your evaluation so that you can get your CME credit. Our next Bone Health Echo, I'm going to let Andrea tell you guys about that, and we look forward to the next call. Please reach out to any of us if you have any questions. We want to see case presentations. Please don't be shy. There's no dumb question, no dumb case. Every patient deserves excellent value, which you're giving them. So reach out to us, your colleagues, and we'll be glad to help you navigate with some of those patients. Thank you all again so much. And Andrea, I'm going to turn it over to you.
Okay, so as you mentioned, remember to do your evaluations. I sent them in the email yesterday, and also I included it in the chat as well. So please copy and paste that, do your evaluation. It'll be open for 1 week. And if you don't have access to it or something happens, just please email me you can email at info@nbha.org. if you have any questions. The next FLS Echo session will be on a Thursday again from 3 to 4 p.m. Eastern Time on December 14th.
And who is our speaker for that? Do we have?
Oh, give me a second. If I can pull it up. I know it's on the mechanisms of action for anabolic therapies.
Okay, great. That's right. We're going to do, Dr. Dave Dipster is going to do MOA of anabolics. It will be valuable information for treatment planning. All right. Well, thank you so much. And again, we appreciate your participation. Thank you, Andrea.
Okay. Have a good one. Bye, everyone.
Great.
Bye.
Dr. Lewicki.
Yes.
Hey, you're still on. Good.
I'm still on, yeah.
Thank you. Thank you.